Good evening. I'm very pleased to be here tonight. And while I was called a doctor, I'm the wrong kind of doctor here tonight. I have a PhD in electrical engineering. I spent 22 years at Intel Technology Development. I was the designer of first flash memory for Intel and went on to become a Pentium senior manager in the Pentium design. So how did I end up here tonight? About 10 years ago, I invested as an angel investor into cardiovascular technology. It became a company, and while doing my due diligence, I got deep into cardiovascular space, at least in the aspects of the heart as an electrical device. After all, it's an antenna, to put it simply. So before I go in and tell you a bit more about the problem we have solved here, we believe, I wanted to thank Alexei Shvilkin, who is at BI Hospital at Harvard Medical School, who has been working very hard with us to make this technology a reality. So, of course, let's talk about the problem first. No matter how cool the technology is, it's just going to stay that cool without actual problem that it addresses. So I'm going to remind you of some of the statistics about cardiovascular disease that are related to ACS, if you want, or heart attack, acute coronary syndrome. There are about 800,000 heart attacks each year in the United States. 200,000 or so are repeated heart attacks. These are the people that have been intervened on and have been told that they are very high risk. The next statistical point that I wanted to emphasize here is there are about 8 million people in the United States that were intervened on for ACS, or at least coronary artery disease. So all in all, the population of 8 million is, according to our research, very receptive to a tool that would help them when they experience chest pain or they perceive to have a chest pain. They're facing the constant fear of another heart attack. They're basically trying to self-diagnose themselves, and there is no tool out there that will help them make that decision. Should I run to the ER, or is this another indigestion? How can a patient actually influence the medical outcome? Only by one thing, basically. When they have chest pain, ischemic event, their reaction time will be critically important for the outcome, for that intervention that's in front of them. So research has shown that about 30-minute delay in intervention results in about mortality rate increase of about 7.5%, and pre-discharge heart failure rate increase of about 8.7%. And yet, multiple research papers have shown that time to intervention for an ACS patient is about 3 hours. And lion's share of that delay is indecision by the patient, trying to decide how should I react to this chest pain. Denial, all kind of human factors, copay in the ER, etc., etc. But the reality is that 3 hours is a lot. And time is muscle, as cardiologists say. So in that sense, we are looking at 3 hours that have been tried to be improved by door to intervention time, but nobody could do anything really about the time that the patient takes to actually decide what to do. And that's what we are tackling here. And that's patient side of the thing, medical side of the things. Well, there's a big economic impact as well, because the other side of the coin, many people scared of the heart attack run to the emergency room without good reason to do that. And about 7 million annual visits for the chest pain in the United States to the ER. Out of those 7 million, about 6 million are unnecessary. driving up the bill to about $10 billion or more. So what would be the ideal solution for this problem? The ideal solution for that problem would be that every high-risk patient would have a cardiologist and a 12-lead ECG machine with them 24/7. So what would cardiologists do? When there is an episode of chest pain, they would look at the pre-existing risk, right? They would look at the chest pain characteristics, ask the patient, and they would take a 12-lead ECG in patient's home, right, outside. All this is assumed to be outside of the medical facility, indeed. And they would look at the 12-lead ECG and then integrate all this in their head into a clinical picture and decide, is this a red light, yellow light, or a green light? Is this a highly likely ACS event? Call 911, cath lab in front of you. Or additional testing is needed. It could go either way. Or this is very low risk, reassure the patient. So that would be the model, basically, if you had a cardiologist with high-risk patients 24/7. So that's exactly what we wanted to achieve here. So basically, the assumption here was it's all outside of the hospital. It's 3 o'clock in the morning and patient wakes up with that chest pain, right? What does the patient do? So we built this technology, and I'll show you the hardware part of it is a credit card sized device that for 30 seconds you press against your chest, and it gets enough information to build a vector electrocardiogram for XYZ, as we have talked about. And all our diagnostic work is done in vector space. So we have XYZ. We really don't need a 12 lead because we have a XYZ indeed. And so our diagnostic engine integrates risk, chest pain characteristics, and this ECG characteristics that is, again, a vector base, and it has a brand new marker that we have come up with in the vector space for ACS. And the outcome from all this is patient gets red light, yellow light, or green light in terms of what do they need to do. Their question is, what do I do? What is the best for me in terms of going to the ER or not? So we've done a number of studies here to show the performance. And this is the chest pain study. And we took 110 consecutive patients in an ER, busy ER, urban ER, and basically had a panel of 3 cardiologists who had ECG information, risk information, and actually the description of the symptoms, and compared that performance to the performance of our automated eye cardiologist, as we call it. As you can see on the left-hand side, the specificity numbers were very similar between the panel of 3 cardiologists and our system. And in terms of sensitivity, we were a little bit better, but statistically the same. So in order to show that indeed our subscribers, because we're going to be selling this on a subscription model, this is an alarm for your heart, it's continuous service, our subscribers will be not sent to the emergency room for no good reason. We have done about 1,200 recordings on healthy volunteers, and we have shown that none of them was sent to the emergency room. So that's very encouraging indeed. Although the ECG, even our highly sensitive marker, was positive in about 80 cases, the system as a whole ruled out ACS and said, you're fine. So that's a big data enabler, because without that, we will never have a big data. And big data is what we are after here. Why? Because in the longitudinal manner, we will follow our subscribers, our patients over the years, and we will be able, with this rich data set of the electrocardiogram in the vector space, we'll be able to learn a lot about preventive value and predictive value as well. So this was very encouraging indeed. And how did we do on our proprietary marker? We basically compared just ECG, 12-lead ECG reading of the highly skilled cardiologist to our proprietary marker. And how did we do that? We've done that by angioplasty. 66 patients, 122 arteries occluded, and we mixed them with negative controls, and basically showed, all that showed to a very highly skilled cardiologist, and also have actually measured to our eye cardiologist system our proprietary marker, vectorial marker. And remarkably, we were about 20% more accurate, sensitive, and specific than some of the best cardiologists in the world. How did we do that? Well, the secret is in that three-dimensionality of the signals that we actually collect here. And we are sort of scanning the heart. So our gain was back of the heart, side of the heart, and indeed that was very encouraging. So all in all, at this point, first of all, we are raising money. And secondly, I wanted to encourage questions, because this is a short presentation that really probably generated equal number of questions than it answered.
2 questions. We'll start on this side.
Does it integrate with any health systems today? If they want to push out this information to any of the doctors, the PCPs or the cardiologists, does it communicate to the health system?
At this point, we have built an app if physician wants to be part of this, but we don't have integration yet with the electronic health records.
Any liability issues if it fails?
Well, that is the same question that you would ask the cardiologist that was with that patient in that living room or bedroom in their home with a 12-lead ECG. We are as good or better than the cardiologist. So is the population better off with an imperfect test, which is a cardiologist and 12-lead ECG machine, or is the status quo there? So at the population level, we'll save many lives, you save dollars. Can you zoom in on an adverse event, as you can with any physician, right? Outside of the hospital, doesn't have troponins, et cetera, yes. But the net benefit will be huge.
Thank you very much.